I think right now okay. Hello everyone. My name is Elijah. My Chinese name is Quing Zhang. And today I want to talk about a topic about dizziness. So I have seen many patients with complaints of dizziness came to the clinic, but sometimes we need to what fascinated to me is the different causes of the dizziness, and I want to make have some deeper thought about dizziness. So diagnosis is very important with dizziness. And because there are various etiologies of dizziness, as we can see, the 40% can be due to the peripheral vascular dysfunction. And the green one, the 10% of brainstem vascular lesions. And 15% is psychiatric disorder. So these patients with they have no nystagmus or a physical examination positive, but they describe they have dizziness. It's actually psychiatric disorder. And for other problems like not associated with the brain, like presyncope and disequilibrium, so these problems can be contribute to 25%, and we cannot make the diagnosis for 10% of the patients. So the general approach for this is we really can do some physical examination, and we can see some positive physical examination, like the positional changes in symptoms, when the patient is lying down and from lying down to stand up, he has dizziness. And sometimes it can be due to the pressure, it can be due to the blood pressure. For example, the patient has orthostatic hypotension. The patient would feel dizziness because of the low blood pressure. But sometimes it can be due to BPPV. So, sorry. And it's otoliths in the canal, in the semicanal. Sorry. Sometimes we can observe the gait of the patient. For example, there are problems of the cerebellum, different the attack, if the patients have ataxia, maybe due to spinothalamic tract or the spinal vascular tract. So different kind of gait we can see. And also, if you detect the nystagmus in the patient, it's almost the vertigo. So, so dizziness, most reasons for we can see is the vertigo is mainly the main reason for the dizziness, but not all patients can have the sensation of vertigo. So for psychiatric disorder that it is not detected prior to standardized psychological testing using the diagnostic interview schedule. So if you want to know more about the vertigo, we need to get really deep into the anatomy of the brain. So vertigo is the predominant symptom that arises from the acute asymmetry in vascular system. And we need to know the vascular system contains several tissues like the vestibular apparatus and brainstem and cerebellum. And the vestibular cochlear nerve can have two branches. One is vestibular branches, one is cochlear branch. The cochlear branch is mainly for hearing, but the vestibular branch is mainly for the vertigo. So for the keep balance sensation. And you can see the vertical branch can from the semicircular canal, which mainly the ampulla, to the vestibular nucleus, and the utricle and the saccule also give fibers to the vestibular nucleus. So the semicircular canal ampulla to the vestibular is mainly the dynamic equilibrium, and the utricle and the saccule to the vestibular is the static equilibrium. So there are two different kinds fibers that came together for the equilibrium, no matter dynamic or static. And from this picture, you can see the two kind fibers that give the vestibular branch and to the internal acoustic meatus, which the facial nerve also go through this canal. And so that's why it can be associated with the facial nerve damage if there's the vascularitis. Nervitis can cause the facial nerve damage. And from here, go to the vestibular nucleus. There are 4 destinations of the vestibular nucleus. So one is from the superior and inferior to the cerebellum, especially the fastigial nucleus, and then the cerebellum would give back fibers through the inferior cerebellum tract back to the vestibular nucleus. And then, so the connection between the vestibular nucleus and the cerebellum could give the patients different sense of the position. And if there's damage of cerebellum or the vestibular nucleus, so the patient cannot keep balance. And another connection is vestibular would give tract to the ventral horn of the motor neuron. So you see is the vestibular spinal tract, and then from the vestibular spinal tract to the ventral horn, the motor neurons would give motor nerve to the extensor muscles. So we know that extensor muscles are anti-gravity muscles. It can keep us to a position of standing. So it's very important to sustain the position of standing with the extensor muscle. So one destination to cerebellum, one destination to the vestibular spinal tract to the ventral horn motors, and then another is to the vestibular nucleus would give fibers to the abductor nucleus, and from abductor nucleus to the MLF, which the medial longitudinal fasciculus, to the cranial nerve 3 nucleus, cranial nerve 4 nucleus. So it is associated with our eye, when we're hearing something, that we can keep the eye to focus on something. And also, if there's a damage here, there would be nystagmus. There would be mainly horizontal nystagmus. But for the cranial nerve 4 nucleus, we can see also the vertical nystagmus and torsional nystagmus. So different kinds of nystagmus, but mainly horizontal nystagmus. And so this is the definition to the muscle control our eyes. And another is from the, as we can see, it's the upper one to the VPM, to the thalamus, the ventral posterior median of thalamus. And then from here, it would go to the cortex, like lateral post central cortex, insular cortex, temporal parietal cortex. So to the thalamus, these are mainly sensation. So we can feel dizziness, we can feel vertigo, we can feel the lightheadedness. It's all associated with this sensation tract upper to our brain. So we know that from the semicanal and the ampular to the vestibular nucleus. Vestibular nucleus has 4 destinations: cerebellum, the vestibular spinal tract to the ventral horn, motor neuron, and also to the nucleus that controls of the eye, and also to the cortex. We feel the sensation. So this is the foundation of how we understand the vertigo associated with other symptoms. And also, if we want to know more about the vertigo sensation, we need to know that other associated symptoms, that because the vestibular nucleus is here, we can see is in the medulla, and also there are several nucleus that close to it. For example, the spinal trigeminal nucleus. So if there's damage, there would be ipsilateral facial loss of pain and temperature. And the inferior cerebellum peduncle, if there's damage, there will be ataxia. And also there's nucleus ambiguous. There would be diminished gag reflex, dysphagia, dysphonia. And also the spinal thalamic tract. If there's damage, there will be contralateral loss of trunk and extremity pain and temperature sensation. So this is called lateral medulla syndrome, which can be contributed to the ischemia of pica, posterior inferior cerebellum artery. And also, we can see other nucleus, like the facial nucleus, it is close to it, the abducens nucleus. So all these brain ischemia damage that can cause vertigo and other nucleus damage and cause different symptoms. So when we see these symptoms, that we should bear in mind is for these patients, you really need to know that these are sensory, the central problem, and not the peripheral. And when we talk about patients, often experience vertigo as an illusion of motion. Some patients can have self-motion, some patients can have the motion of the environment. So it's patients often describe as a spinning sensation. They describe whirling, tilting, or moving. But sometimes they describe it as vague dizziness, imbalance, and disorientation. So all these symptoms, at last, we find out is vertigo. But the quality of the spinning of the vertigo, like spinning sensation, is often not reliable. So maybe you think that the spinning sensation is the vertigo, but actually it's not always the case. So we need more useful features to the vertigo. The first thing is the time course. For acute prolonged severe vertigo, we can see in the vascular neuritis stroke. For recurrent spontaneous attacks, we can see in the mania disease, vestibular migraine. For recurrent positionally triggered attacks, we can see the benign paroxysmal positioning vertigo. And for the chronic persistent dizziness, we can see in the psychological disease and cerebellum ataxia. And another useful features is provoking factors. For example, the positional vertigo and the postural presyncope. I think I have said this. Both are associated with dizziness upon standing. So when you are from lying down to rising from bed, you can feel dizziness. But the positioning vertigo is often, if not associated with the pressure, blood pressure. So when you change head position without lowering blood pressure or decreasing the cerebral blood flow, you can still see the patients have vertigo and nystagmus sometimes. So for example, you can let the patient lying down and rolling over in bed and bending the neck back to look up. You can see nystagmus. But for postural presyncope, often the patient needs to get up because when the patient get up, the lowering blood pressure or decreased cerebral flow makes the patient dizziness. So this is different. So you can change on the bed, and then there's nystagmus or a vertigo happens. You can see it's positional vertigo. And also there's some aggravating factors like worsening by moving the head. We can I have said. And the associated signs and symptoms like nystagmus. And for example, there's a Dix-Hallpike manual. It's mainly positive for BPPV.
The Dix-Hallpike maneuver is performed whenever BPPV is suspected of complicating dizziness. The head is turned 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur. Eye twitching that rotates is called torsional nystagmus. Side-to-side eye twitching is called horizontal nystagmus. Eye twitching that goes up and down is called vertical nystagmus. The Dix-Hallpike maneuver is then repeated on the opposite side. This maneuver should be repeated several times to document for fatigability. When performing this maneuver, another individual can help. Please note that feeling dizzy but without nystagmus is not considered diagnostic for BPPV. Eye twitching must be present for BPPV to be diagnosed. Rotatory nystagmus indicates posterior canal BPPV for which the Epley maneuver is performed. Lateral nystagmus indicates lateral canal BPPV for which the Lemper's maneuver is performed. Vertical nystagmus indicates superior canal BPPV for which the maneuver can be performed.
Okay, so mainly the Dix-Hallpike maneuver can be tested positive nystagmus when there's BPPV. But BPPV is peripheral vertigo. But we should bear in mind usually the nystagmus would be horizontal nystagmus in peripheral vertigo. But BPPV is the special one. So that's what we should bear in mind. We can often see the vertical nystagmus or the torsional nystagmus, not only the horizontal nystagmus. And postural instability is the patient has difficulty maintaining steady upright posture. For the peripheral, sometimes there hearing loss, duration and progression, whether it's unilateral or bilateral. And sometimes we can find the complicated symptoms we can see discharge or drainage from the air. The patient have the tinnitus or history of otitis. And the brainstem sign, I have already said the inferior cerebellar peduncle with staggering or ataxic gait. It could be due to this damage, the inferior cerebellar peduncle or the cerebellum problem. And the vomiting and headache, if there's intragranular hypertension, the double vision, visual loss, slurred speech, this can be due to the the nucleus of the brainstem, and numbness of the face or body, like the trigeminal nucleus and the spinal thalamic tract. So this brainstem sign that we should always bear in mind. So that's the central vertigo associated symptoms. And for the clinical evaluation, first we should focus on the history. We should determine its onset. We say it's acute or chronic, is episodic or continuous. The triggers, and if there are some triggers like the position and the duration of the vertigo is several seconds, like less than 90 seconds is BPPV, but if there's minutes or hours or days, it could be associated with mania or other causes. And identifying the following associated features may help to differentiate between central and peripheral vertigo and the risk factors for ischemia, stroke, and features of any underlying etiologies. So this is history. And the physical examination, you should perform the orthostatic vital signs to rule out orthostatic presyncope. So it's very important to rule out something associated with blood pressure and heart disease. And conduct a neurological examination includes the cerebellum features and the full cranial nerve examination, including evaluation of the nystagmus. So I will talk more about the nystagmus later, and the examination of the gait. So if there's, for example, cerebellum problem, the inferior cerebellum peduncle, cerebellum tract peduncle, and also with some associated symptoms like the basal ganglia damage, like Parkinson's disease. So all these patients can different kind of gait, but also they have the problem with the vestibular nucleus. So will be vertigo. And the targeted examination, most important is HINTS examination to screen for central cause in acute vestibular syndrome. And consider Dix-Hallpike maneuver or other provoking for BPPV, like I have just displayed. And now we'll talk about the peripheral and central vertigo, the difference between the two kinds of vertigo. So the peripheral vertigo is the cranial nerve features, cerebellum features, typically absent. So no dysmetria, no dysphagia, no dysarthria, no diplopia, and only mild gait disturbance. But we can see the nystagmus. And the central vertigo, as we can see, there are many positive brainstem signs, and very severe ataxia. And nystagmus, I will talk later, is unidirectional position, frequently horizontal. And central is horizontal, torsional, or vertical. We can all see in the central vertigo. So what is unidirectional? Unidirectional means it's only one direction. So the nystagmus is one direction. So you put your finger, let the patient to look at your finger. That nystagmus is always the same direction. But central vertigo is not one direction. So when you let the patient to see right and the left, the vertical, the nystagmus can be different. So not one direction. And the hearing loss, the peripheral vertigo is common. There's hearing loss, but the central vertigo is rare. But sometimes if it's associated with the brainstem damage, it's actually some blood vessel that to supply and in the ear, it will cause the hearing loss. But most hearing loss could be due to the peripheral vertigo. And other focal neurological deficits is absent, like I said. And sensation of motion, the peripheral would be very severe, but the central vertigo is mild because our brain has the often because it's not only about the vestibular nucleus give us the sensation, so it will be mild, and the nausea and vomiting, it could be very severe in peripheral vertigo. And now I will talk the very important physical examination is how hints, head impulse test, and the nystagmus and test of skill. So we should bear in mind that symptomatic, it is only indicated in symptomatic patients with acute vestibular syndrome. So the head impulse test for peripheral vertigo is often abnormal. There's corrective saccade to midline with rotation of head. It means when you let the patients in front of you, that you use your hand to move the patient's head right and left, just 15 degrees, I think. You let the patient to see your nose, and you will find out sometimes the patient has the corrective saccade. It means it cannot always look at in your nose, but it will correct it. But for central vertigo, there's no corrective saccade. And nystagmus for peripheral is directional. Like I just have said, is one direction. So no matter you want the patient to look at your finger, no matter which the left or right is the nystagmus, the first phase nystagmus is always the same. And but the central vertigo is different. And also we can not only see horizontal nystagmus, we can see the vertical or torsional nystagmus. But peripheral vertigo, only BPPV that we can see the vertical or torsional. Most of the peripheral vertigo only horizontal. And the next test is a test of skill. So you let your hand to cover the patient's one eye. So just alternating your hands to cover it, that's right and left, and you see when you just uncover the hand, you see the eye is the squid of the eye. It would look at in the up. Usually look down. So there's a skew deviation in the central vertigo. So it's to screen the central cause of vertigo, is especially stroke. So this is very important physical examination. And if the hints testing suggest central cause of vertigo, begin urgent management and obtain neuroimaging. And now, after the history and the physical examination, we can look at the neuroimaging. So the clinical findings suggest a central cause of vertigo. For example, when you see the focal neurological deficits, you give the patient MRI. The concurrent severe headache, hence examination suggests of central vertigo risk factors for ischemic stroke. So these are all we can do the MRI of the brain with or without a magnetic resonance angiogram. And the findings, often there are some abnormal findings, maybe seeing the patient with ischemic stroke, demyelination, and the tumors. And but for peripheral causes, most of them are typically normal. And additional studies. So we should consider based on the patient history, like a CBC, BMP, POC glucose, vitamin B12. If the patient's having some medication, you think that it may be associated with some medication, there should be serum drug levels and the urine toxicological screen. This is important for if you suspect the patient have drug abuse. And the ECG to evaluate for suspected cardiogenic syncope or arrhythmia, because sometimes the cranial nerve 10 that could contribute to the patient's dizziness. And audiogram to evaluate the sensorineural hearing loss, like for example in mania disease, labyrinthitis, vestibular schwannoma, and cataract testing to detect unilateral peripheral vasculopathy, although it's often not used in the clinic situation. And the cause of vertigo, there are many causes of vertigo. The central causes, the vestibular migraine, so it must fulfill all the criteria of the migraine. And the brain ischemia, cerebellum infarction and hemorrhage, carrier malformation, multiple sclerosis. You can see the optitis and all these demyelination symptoms, episodic ataxia type 2. And the peripheral causes, there are many peripheral causes, BPPV, vestibular neuritis, herpes zoster, octus. Like you can see, you need to bear in mind this virus, whether you see herpes zoster of the patients in the air, and the mania disease, labyrinth concussion, lymphatic fistula. So if the fistula, the endolymph and the perilymph, the high potassium and high sodium, the lymph would mix together, would cause vertigo. And the semicircular canal dehiscence syndrome, there's the bone lesions, and the Cogan syndrome, this autoimmune disease, could do damage to the eyes and also the inner ear. And recurrent vasculopathy, acoustic neuroma, and aminoglycoside toxicity, otitis media. So all these causes we should always bear in mind. And for dizziness, so we have talked about a vertigo, but for other, it is not a vertigo, but it is dizziness. The cardiac and the neurological disorders, for example, the presyncope and syncope, it could be cardiac, non-cardiac, and other neurological vertigo mimics. For example, the focal seizures and epilepsy, the sensory ataxia that reduce the proprioception, and the peripheral neuropathy, they can all give, because they would do damage to the spinal, to the tract, to the spinal tract, and to the cerebellum, to the cerebellum peduncle. So all these things would cause the vertical mimics because there's ataxia, sensory ataxia. And neurodegenerative disorders, Alzheimer's disease, Parkinson's disease, like I said, it to damage basal ganglia, ophthalmic sclerosis. So all these things can have vertigo. And other causes of dizziness, the metabolic abnormalities, electrocyte disturbance, for example, the hyponatremia, hypokalemia, hypocalcemia, and sometimes hypoglycemia would cause dizziness. And there's also the persistent postural perceptual dizziness. It's a chronic sensation lasting more than 3 months without cochlear symptoms. So the patient only feel dizziness. It is often after one acute vertigo, but after that, the patient would always feel dizziness. It's not a vertigo, but dizziness. So these kind of patients often suffering anxiety or depressive disorders, these psychological disease. And some medication and other substance with like alcohol, recreational drug use could be the adverse effect of this medication. And the functional dizziness, like I said, is anxiety disorder, panic disorder, somatic symptom, and the related disorder. So for these patients, they should see a psychiatrist. And this is a brief assessment of dizziness. So patients, if the patient feel dizziness or vertigo, the first thing is the timing is episodic and continuous. If it is episodic, it is triggered or spontaneous. If it is triggered, so you do the Dix Hallpack maneuver. It's positive, it's BPPV. If it's negative, access for orthostatic hypotension. And if it is spontaneous, whether you find hearing loss, it may be mania disease. If you find some migraine criteria, you will see the migraine headache, the vascular migraine, and if the patient have some psychiatric symptoms, maybe associated with panic attack, psychiatric condition. And if the dizziness is continuous, is it, you should ask the past mental history, is it associated with trauma, or toxin, or spontaneously? The trauma, toxin, the barotrauma, the medications could give damage to the brain to cause dizziness. If it's spontaneous, you do the Haynes examination, like the health pulse test, nystagmus, and the skew test. So if I already said that the peripheral etiology could be due to vascular neuritis, you will see the saccade. So it's also the nystagmus is unidirectional. It's often horizontal, and the normal test of skew. But if you cannot see saccade and the nystagmus dominantly the vertical or torsional, and there's gaze evoked bidirectional abnormal of the test of skew, it's mainly the central etiology. So you will have the patient to have the MRI, and you find a stroke or autoimmune disease like multiple sclerosis. So this is what I want to talk about the dizziness, different the approach to dizziness. So that's all. Thank you.